Welcome to the VetEmCRIT Academy, where we discuss veterinary emergency and critical care and science-based tools for veterinary professionals. In this video, I will talk about the use of point-of-care ultrasound and diagnosis and monitoring of undifferentiated shock patients. Point-of-care ultrasound, or POCUS for short, is an invaluable diagnostic tool that I have been using for a very long time during my career in emergency and critical care medicine. The rush exam, or rapid ultrasound in shock, was first described in 2009. It involves a three-part bedside physiologic assessment, simplified as the pump, the tank, and the pipes. The evaluation of the pump allows a clinician to assess cardiac function and rule out pericardial effusion. The evaluation of the tank helps a clinician to assess the volume status. And finally, the pipes portion of the exam is a little bit less applicable to our population of patients because the main goal in human medicine is to detect deep vein thrombosis in lower extremities, which rarely occurs in dogs and cats. First recommended step is the evaluation of the pump to exclude the presence of pericardial effusion. Identification of pericardial effusion may be an easy task. However, in some cases, it may be tricky and challenging. It is important to differentiate between pericardial and pleural effusion. Also, you want to note the amount and echogenicity of the effusion. The next most important goal is to decide if pericardial effusion is causing a cardiac tamponade physiology or not. Cardiac tamponade physiology occurs when the pressure within the pericardial sac is higher than pressure within one or more of the cardiac chambers, resulting in impaired diastolic sealing of this chamber. Classically, right atrium is compromised first. However, it may be different in patients with heart defects or severe pulmonary hypertension. By the way, you can download the guideline on the acute management of pulmonary embolism in dogs and cats by clicking the link in the description below. It is vital to remember that cardiac tamponade is a clinical diagnosis, meaning that echo may be suggestive of tamponade, but the final diagnosis requires the evaluation of the whole clinical picture. For example, imagine you're presented with a patient in shock who has mild to moderate amount of pericardial effusion. Since you cannot identify any other causes of shock, you decide to perform pericardiocentesis despite its only mild to moderate amount. If this patient's shock resolves after you drain the pericardium, this will allow you to make a diagnosis of cardiac tamponade. It is rare when small amount of pericardial effusion is causing cardiac tamponade. However, it is possible in an acute situation when pericardial sac is stiff and non-compliant. Echocardiographic signs of cardiac tamponade may include diastolic collapse or serpentine deflection of the right atrial wall during diastole when the tricuspid valve is open. As the pericardial pressure continues to rise, the right atrial, left atrial, and right ventricular walls may get collapsed as well. It is common to find a dilated, non-compliant caudal vena cava in patients with cardiac tamponade due to the presence of very high right atrial pressure. This patient has both pleural and pericardial effusions. However, pleural effusion predominates and only a small amount of pericardial effusion is present. To differentiate between the two, it is important to identify the bright echogenic pericardial sac that usually has a circular shape surrounding the heart. This is a right parasternal long axis view of the heart. There is moderate to large amount of pericardial effusion that is surrounded by a hyperechoic bright structure representing a pericardial sac. Free right atrial wall is partially collapsed, suggestive of the true cardiac tamponade physiology. This is a very similar image. However, you may appreciate a complete collapse of the atrial wall and partial collapse of the free right ventricular wall, consistent with severe cardiac tamponade. There is also pleural effusion present. This is a left apical 4-chamber view. there's moderate to large amount of pericardial effusion resulting in partial right atrial and right ventricular wall collapse. Any ideas what's going on here? This is a subxiphoid view. The top of the screen represents a portion of the liver that is separated by a thick hypercardic bright line, which is the summation of the diaphragm and pericardial sac. Next, there is a thick layer of the hyperechoic pericardial effusion. This patient has a hemopericardium, and its pericardial space is occupied by clotted blood. The most common cause of true acute hemopericardium in veterinary medicine is the left atrial rupture in patients with severe mitral valve disease. In patients presenting with shock, a brief eyeball method in assessment of LV contractility is recommended. By the end of this step, an emergency veterinarian should be able to tell if the patient has a hyperdynamic, normal, depressed, or severely depressed left ventricular function. Three main components of LV function assessment include the following. First, estimating the endocardial excursion, in other words, movement of each portion of the endocardium towards the center of the heart. Second, myocardial thickening based on the fact that the LV wall with normal function will get thicker during systole. The third component is the septal motion of anterior leaflet of mitral valve. Normally, anterior leaflet should come closer to the interventricular septum because lots of blood is moving through the mitral valve during diastole. If the leaflet approximates the septum, the function is good. If the distance between the leaflet and the septum is large, the LV function is likely decreased. This sign, though, was recorded by our ICU point-of-care ultrasound machine. This is a standard right peristernal long axis view obtained from a standing dog. If you look at this heart, LV has a pretty good endocardial excursion. The interventricular septum and the free LV wall gets thicker during contraction, and finally, the anterior mitral leaflet is almost touching the interventricular septum at the end of diastole. Based on this eyeball assessment, we can conclude that this dog's LV function is normal. This is a right peristernal short axis view obtained from the same dog as in the previous slide. Here you can appreciate two papillary muscles in so-called mushroom view. The quality of the image is relatively good given that it was obtained by the non-cardiology ultrasound machine in a standing dog. Similar to the long axis view, you can appreciate a good endocardial excursion and thickening of the interventricular septum as well as the free LV wall during the systole, which is consistent with normal LV function. When assessing LV function, it is very important to avoid oblique views due to the so-called cylinder tangent effect that occurs if the plane of the beam enters the chamber or vessel at a tangent, which falsely reduces its diameter. For example, this image is a transverse view of the canine thorax obtained by a CT scan with contrast. If you put the ultrasound beam at the level of the papillary muscles, you will get a standard right peristernal short axis view. If you redirect your beam towards the left ventricular apex, the ventricular walls will appear thicker and the LV lumen will appear smaller. By obtaining an oblique view in a dog with impaired LV function, it may be misinterpreted as normal or even hyperdynamic. Therefore, it is important to visualize the papillary muscles and to acquire classic mushroom view when interpreting LV function in the right peristernal short axis view. The same cylinder tangent effect may occur when you image major vessels, such as the Caudal Vena Cava. If the ultrasound beam fails to be directed through the center of the vessel, and instead the beam is tangent to it, the diameter of the vessel may be underestimated. This is an example of a hyperdynamic left ventricle. Here, you can appreciate a small LV lumen during systole and vigorous hyperkinetic contractions obliterating the ventricle in systole. Also, you can appreciate so-called kissing of the papillary muscles that come in contact during LV contraction. Hyperdynamic LV is traditionally associated with a hypovolemic shock. However, its presence doesn't always equal to volume depletion in your patient. Besides hypovolemic shock, it may occur in patients with distributive shock or global vasodilatory state. Arterial vasodilation causes decreased afterload for the left ventricle, making its job much easier. In addition, commonly increased sympathetic tone during the state of distributive shock further increases LV contractility. As a result of reduced afterload and endogenous catecholamines effects, LV may appear hyperdynamic in the absence of hypovolemia.
By the way, you can download a free diagnosis of shock checklist and treatment of congestive heart failure cheat sheet by clicking the links below located in the description.
This slide compares normal and hyperdynamic hearts back to back for better appreciation of the differences between the two contractile states. To the left, you can see the left ventricle with normal contractility, and to the right, hyperdynamic left ventricle. Finally, this is an example of the hypodynamic heart. The video clip in the center represents a right parasternal long axis view. If you look at this heart, there's minimal endocardial excursion towards the center of the LV. The interventricular septum and free LV wall don't get thicker during contraction. Finally, the anterior mitral leaflet is barely moving. Therefore, there's a huge distance between the leaflet and the interventricular septum at the end of diastole. Based on this eyeball assessment, we can confidently conclude that this dog's LV function is hypodynamic. On the right parasternal short axis view, you can appreciate very similar findings: poor endocardial excursion and a lack of wall thickening during systole. The main objective of the right ventricular assessment is to document signs of right heart strain, which may be a potential sign of a large pulmonary embolus resulting in obstructive shock. The RV may be evaluated in different echo views, including right parasternal short and long axis views depicted here. On right parasternal short axis view, RV is smaller than LV, and it has a characteristic crescentic shape because it is wrapping around the circular shaped left ventricle. The RV walls are visibly thinner than left ventricular walls because RV is working against much lower pulmonary pressure. On the right parasternal long axis view, the RV has a V shape. The RV to LV ratio is usually 0.6 to 1. In other words, RV equals to about 2/3 of the size of the LV. Most of the RV systolic shortening occurs in the long axis, as opposed to the left ventricle, which shortens by 80% in the short axis. By knowing normal anatomy and function of the RV, one can detect signs of RV dilation and strain on bedside echo. These signs include the following. First, increased RV to LV ratio. Second, RV may become an apex-forming ventricle on the four-chamber left apical view, which is not normal. Third, due to the RV dilation and strain, it may deflect the interventricular septum towards the LV lumen, causing a D-shaped LV. Finally, RV wall may get thickened due to high strain and increased work. This is an example of severe RV dilation visible on the left apical four-chamber view. In this case, RV to LV ratio is 1.26 instead of normal 0.6. For comparison, the image to the right represents a normal heart with preserved normal ratio between the right and left ventricles. This is another example of severe RV and RA dilation on the subxiphoid view. You can easily appreciate that the right chambers are much bigger than the left. This is a great example of severe RV dilation on the right parasternal short axis view. In this case, instead of having a crescent shape, RV has almost circular shape and causing flattening of the interventricular septum, leading to a D-shaped LV. Okay, now how can you integrate the results of the RV assessment into your ICU practice? If RV size is completely normal, that will exclude pulmonary embolus as a sole cause of arterial hypertension. It will not allow you to completely rule out PTE, but it will let you rule out PTE as a cause of obstructive shock. If you document severely reduced RV function in a patient with shock, you should consider the use of inotropes, pulmonary vasodilators, and other drugs such as thrombolytics, vasopressors, and even fluids versus diuretics in some patients. It is important to reassess response to therapy with serial exams that may add value to your diagnosis and case management. By the way, you can download the guideline on the acute management of pulmonary embolism in dogs and cats by clicking the link in the description below. There are 3 different locations where caudal vena cava can be imaged with the ultrasound: subxiphoid U, portic hepatis, and abdominal portion of the caudal vena cava or CVC. The subxiphoid U is the most common location to image the CVC. A sagittal view of the abdomen obtained by a CT scan is depicted on the screen to facilitate their understanding of the anatomy and location of the caudal vena cava. To image the CVC at the subxiphoid side, a transducer is placed longitudinally under the subxiphoid process and angled cranially to visualize the diaphragm. The ultrasound probe is found to the right of the midline until the CVC should be identified at the point where it crosses the diaphragm. Then, the ultrasound probe is slowly sent off either side of the CVC and returned to the position where the CVC subjectively felt to be at its widest diameter. Alternatively, CVC crossing the diaphragm can be imaged in the portic hepatis view. To locate the portic hepatis, the transducer is placed parallel to the ribs, transfers to the CVC and aorta at the 10th to 12th right intercostal space, approximately just below the paxillary muscles in the upper third of the thorax. If aerated lung was encountered, the transducer is angled or moved caudally 1 intercostal space, or the probe is placed dorsally over the paxillary muscles and slid ventrally between the ribs until the portic hepatis is visualized. In cases where the right kidney is identified, the transducer is angled or moved 1 intercostal space cranially. By doing so, a transverse image of the portic hepatis is obtained. The image represents a transverse sonographic view of the portic hepatis with the 3 major vessels: pleural vein, orange, CVC, blue color, and aorta, yellow. Let's briefly discuss the physiology of CVC collapse during respiration. As the patient breathes in, the pleural pressure drops and the negative pressure is generated in the chest. This negative intrathoracic pressure is being transmitted to the right atrial pressure that also drops, leading to increased blood flow from the abdominal to the thoracic cavity. At the same time, expanded chest is pushing down on the abdomen during inspiration, causing an increase in abdominal pressure, further improving the flow of blood from the abdomen to the chest. This combination of increased abdominal pressure and reduced intrathoracic pressure leads to the CVC collapse during inspiration, which normally occurs in healthy humans and animals. In order for the CVC to collapse, intra-abdominal pressure should exceed RA pressure during inspiration. Patients on positive pressure ventilation will have a reverse physiology, since positive pressure breath will cause elevation of intrathoracic pressure on inspiration and CVC distension instead of collapse. There are multiple limitations of the CVC collapse, and CVC collapse does not always equal to volume responsiveness. First of all, healthy animals and people will have CVC collapse on inspiration. This doesn't mean that you have to give fluids to healthy individuals. Second, since CVC collapse happens with intrathoracic pressure drops, shallow breathing, panting may lead to the lack of collapse even if there is hypovolemia or volume depletion. Third, if the patient has increased right atrial pressure due to right-sided heart failure, this will result in a lack of collapse despite the presence of hypovolemia. Third, let's say you have a patient in respiratory distress due to upper airway obstruction. This patient is going to generate very negative intrathoracic pressure. Since the CVC collapse depends on the difference between intrathoracic and abdominal pressure, the majority of these patients will have CVC collapse regardless of their volume status. Finally, abdominal hypertension due to any etiology, for example due to ascites, may lead to CVC collapse even in hypervolemic patients due to the high pressure elicited on the intra-abdominal portion of the CVC. Patients in hypovolemic shock usually have hyperdynamic heart with luminal obliteration and small ties. They tend to have flat CVC with significant respiratory variation, and they also may have peritoneal or pleural effusion in case of hemorrhagic shock. Patients in cardiogenic shock usually have hypodynamic, poorly contractile heart that is dilated. Their CVC is dilated and is lacking respiratory variation. They tend to have B-lines as a result of left-sided congestive heart failure, as well as pleural and abdominal effusion. Patients in obstructive shock may have pericardial effusion in case of cardiac tamponade, RV strain if the massive VT was the cause of the shock state, and potentially hyperdynamic heart if venous return to the heart was obstructed, mimicking hypovolemic shock. Their CVC may be distended in case of cardiac tamponade or PTE, and also they may have absent lung flooding due to the presence of tension pneumothorax. Finally, patients in distributive shock may have a hyperdynamic heart to low afterload and potential volume depletion. However, sepsis-induced cardiomyopathy may result in a hypodynamic heart as well. CVC may be normal or small. They may also have septic pleural or peritoneal effusion. By the way, you can download a free diagnosis of shock checklist and treatment of congestive heart failure cheat sheet by clicking the links below located in the description. If you want to learn more, check out our video on blood gas analysis during CPR.